Hello, everyone. Welcome and thank you for joining us for today's session, Frequently Asked Questions from the American Society of Hematology annual meeting. I'd like to wish everybody a Happy New Year and hope everybody had a great holiday. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I am joined by Dr. Jesus Berdeja from the Sarah Cannon Research Institute in Nashville, Tennessee, and Dr. Sham Mailankody from the Memorial Sloan Kettering Cancer Center in New York City. We've invited them here today to answer some of the frequently asked questions we've received from patients and caregivers about the multiple myeloma clinical study data that was recently presented at this year's ASH meeting. So let's get to your questions. First, we're going to talk a little bit about precursor conditions, meaning smoldering multiple myeloma and also MGUS, or monoclonal gammopathy of uncertain significance. So, Dr. Mailankody, how common is MGUS, and does it always precede multiple myeloma?
It's a good question. So I think the typical number we quote is about 3% of the population over the age of 50 years has MGUS, and the number increases as people grow older. So when you look at people in their 70s and 80s, that number probably approaches 5-6%. I caveat that by saying as we get more sensitive tests like mass spectrometry to detect monoclonal spikes, we will likely, if we start using these more sensitive tests, we'll likely pick an even higher proportion, probably closer to 4 to 5% of the population over 50 years. It's a little more common in men than women. It's more common in Black patients than other groups. It's about twice as common in Black patients, actually. But it's a fairly common condition. Most people are not diagnosed with this because this is not part of a routine physical to do M spikes and light chains typically. But if you did population screening, it's a fairly common condition.
So, and it doesn't always translate into active myeloma, but on average, how long would it take before, if someone is diagnosed with MGUS before they actually are diagnosed with active multiple myeloma?
So the important thing is the vast majority of patients who have MGUS will never develop multiple myeloma. So that's key to remember. About 10% of patients who have, 10% of individuals, I should say, who have MGUS would be expected to develop myeloma in about a 10-year follow-up. So that's 1 in 10 over a 10-year period. Probably about 15 to 20% in a 20-year period. So it's a very infrequent event to progress into multiple myeloma. So that should give some degree of reassurance for those individuals who are diagnosed with MGUS. The reverse is actually true, which is that every patient with multiple myeloma probably had MGUS preceding it, which has been shown by some very nice studies in the past. But the counterfactual, which is having MGUS, does not always lead to, in fact, in the majority of cases, does not lead to development of multiple myeloma.
So, Dr. Berdeja, should healthy adults who are over 40 years old, who have a close family member with multiple myeloma, should they get tested for the presence of MGUS?
No. No. So, but that is the answer. But no, as Dr. Mailankody said, this is an infrequent event. And even though patients who do have family member with myeloma have increased risk of developing MGUS or having MGUS, that risk is still quite small. And actually from the iStop study at ASH, what's interesting is they showed that there was a significant percentage of those MGUS patients that actually had a transient MGUS. And so oftentimes you will pick up something that truly is insignificant and may go away. And so I think the stress of having it and dealing with it, I think, is probably more than the actual risk. So I would just continue with routine follow-up with the primary care doctors and monitoring, but I wouldn't necessarily look for MGUS.
So, Dr. Mailankody, is there any link between COVID vaccination and progression of MGUS to active myeloma? I mean, I actually sat through that presentation at ASH, and I thought it was sort of an interesting connection that people were sort of looking for there. So can you talk a little bit about that?
Yeah, so I think, even before the presentation, which will come to, I think there's little clinical or, preclinical data to suggest they would lead to progression. But at this ASH, I think, again, Dr. Berdeja alluded to the iStop study, which for those of you who are not familiar, is a large population-based screening study that's ongoing in Iceland, where about 75,000 or more patients, individuals, I should say, again, over the age of 40 years, have been screened for MGUS. And the primary objective is to follow these individuals individuals with MGUS over a period of time in 2 or 3 different ways to identify if early diagnosis of MGUS leads to clinical benefits. Now, the advantage of this study is also that it allows us to ask many more questions related to MGUS and its natural history. So one of the questions, one of many questions that was asked at this ASH and answered was, is there an impact of COVID vaccination on progression of MGUS in individuals at a population level? So they had about 1,800 patients who had diagnosis of MGUS. They had their M spike values, light chain values collected prior to COVID vaccination and after COVID vaccination, allowing them to ask if the rate at which the M spikes increase over time accelerated after the vaccination. And the short answer is it did not, providing enough confidence and comfort, hopefully, to our patients that there is no reasons to believe that COVID vaccination would lead to an acceleration of or progression from MGUS to multiple myeloma. And that's consistent with what we've seen since the vaccines have been available for the last 3 years now, with our patients as well, quite consistent with our clinical experience. But this is a systematic study that should provide a high degree of confidence to people.
So I think that was definitely a good thing. So interesting data there. So Dr. Berdeja, are there certain smoldering multiple myeloma patients that should be aggressively treated? And I know that this is sort of a little bit of a loaded question in the field right now. So let's hear your perspective on that. And if they should be aggressively treated, how do you determine which patients might require treatment?
Yeah, so that's an excellent question. I think that is the key, is which patients should be treated. So I think there is a subset of patients that should be treated. The question is how to truly determine who those patients are. So just to back up a little bit, those smoldering multiple myeloma is a diagnosis of multiple myeloma, but where there are no clinical symptoms or signs of active multiple myeloma. And traditionally, patients with this diagnosis have been monitored closely and not treated. There is some data showing that not all patients with myeloma are equal. So there is a group of patients who are considered high-risk smoldering myeloma. And those are patients that by definition have a 50% chance of converting to active multiple myeloma in the next 2 years. And so that is the group where interventions may be helpful. And there are 2 large studies from Spain and from ECOG here in the United States that looked at intervening with lenalidomide plus or minus dexamethasone, and showed actually that you could prevent or delay the onset of active multiple myeloma, and there was a survival advantage to those patients. The problem has been with the definition of high-risk multiple myeloma, in which patients are included, that we continue to struggle how to sort of kind of make these results or how to interpret these results in the general population. But I think that as we get better and start incorporating more and more cytogenetic data, more clinical data, I think we'll have a better idea of who that group is that will benefit. But you will see some studies that are looking at even the possibility that maybe once we have identified this population, maybe we should be treating much more aggressively. And at ASH this year, we actually saw that from the Jim Cesar study from Spain, where patients were getting treated just like active myeloma with three drug inductions and transplant, et cetera, or from Dr. Kumar, who presented the data with KRD, daratumumab, in those patients. And again, it's looking quite promising. But again, the question is whether you make an impact in these patients this early, and can you cure them? Because you are then exposing patients to toxicity that they may not need.
Yeah, I mean, I think that's going to be, sort of on the docket at ASH for many years as people really begin to sort this out. And I think that the one thing that is true is that if you are a smoldering patient, and only you should be treated on a clinical trial, if at all, right? So
ideally.
All right, so we're going to move on to a couple of questions on high-risk multiple myeloma. So Dr. Mailankody, how do you determine if a patient has high-risk multiple myeloma, and what does that actually mean for prognosis?
All right, so this is also somewhat evolving and challenging. So classically, I guess we've used cytogenetics, FISH studies that many patients with myeloma may be familiar with from a bone marrow biopsy, looking at certain genetic changes that a subset of patients with multiple myeloma have that portend a high risk. For instance, deletion of 17p chromosome, where a protein called p53, which is a critical protein in the body, resides, is considered high risk. This is probably present in about 5-10% of patients at diagnosis. Other such genetic events, like, say, for instance, translocation of 1416 or 414, have also been considered a high risk. Depending on which cytogenetic abnormalities include and how you define, probably about 25% or so of patients who are newly diagnosed with multiple myeloma have one or more of these high-risk features. So that's one way to define. Another one is the revised ISS staging, which has been developed over the last few years to stage patients with multiple myeloma into 3 stages. And many of us considered stage 3 by the revised ISS, which, to be fair, includes cytogenetics among other factors like LDH and factors, would also be considered high risk. We also considered things like plasma cell leukemia. Patients who present with circulating plasma cells at diagnosis, I think, are, for all intents and purposes, high-risk disease, and the patients who tend to not do as well with conventional treatments as standard risk myeloma. And similarly, I think patients who have what's called as extramedullary disease, which is myeloma lesions outside of the bone and the bone marrow, would be in many instances associated with a high-risk disease. So as I mentioned, I think the definitions are somewhat evolving and different, maybe from center to center, but these are broad parameters of high risk in newly diagnosed myeloma. One last caveat would be what many of us are now calling as functional high risk, which are patients who do not fit into any of these categories, but inexplicably have disease that does not respond as well or as long as we would expect. Standard treatments that, say, for instance, progress with 6 to 12 months after initial treatments, which is typically not the case for standard risk, would be considered as functional high risk. So that's the definition. And you asked what the implications are. I think the general implications are patients with high risk myeloma tend not to respond as well or for as long as patients with standard risk myeloma, typically, to our available standard treatments. And therefore, many of us in the field feel that these are patients who would benefit from earlier adoption of novel therapies and integration of novel therapies in a hope and tend to achieve deeper responses, longer lasting responses. And also patients who should really strongly consider participating in clinical trials when available of these novel treatments for newly diagnosed multiple myeloma. I will caveat by saying, again, for patients who are listening in, I think not all high risk, having deletion 17p does not automatically mean in bad outcomes. There are patients in my practice and all of our practices where we do have these high risk features, one or more of these high risk features, and patients tend to do well with available treatments. So I wouldn't necessarily consider this as a definite, absolute bad outcome. There are exceptions, there are differences, there are nuances to it. And best available treatments, whether on trials or off trials, are still the best possible options for patients with high-risk myeloma, as they are for our standard risk patients.
So I think that it's really interesting now when you go to meetings like ASH and you see clinical trial data presented, usually there's a cohort of people who are defined as being a high-risk cohort. And it's always interesting to see how those patients respond to the treatment versus patients who aren't in that cohort. So I think that's it's good that the field is really looking into that, because really it's like 20 to 25% of patients really sort of fit into that sort of definition, however you define it, right? So speaking of treatments, Dr. Berdeja, are there specific ways to treat patients who may be defined as being, high risk, however it's defined, and does risk change when patients relapse from a treatment that they might be on?
Yeah, so again, a difficult question, but I think Dr. Mailankody kind of alluded to some of that. I think the important thing is to know that going forward, and for the patient to realize that when you are considered a high-risk patient, the goals are still the same, is to get you to the deepest remission possible, and because that sometimes can overcome that high risk in a subset of patients. So I think that the issue here is actually not necessarily going beyond what the standard treatments are, but I think it's sort of the de-escalation of therapy that's probably more important. And so oftentimes, with high-risk patients, I will continue the same, usually a 4-drug induction, and I will proceed with transplant. But then afterwards, a lot of the standard risk patients get de-escalated to single agent lenalidomide, for example. But with the high risk patients, there's definitely data that you need to continue sort of multi-agent drugs sort of throughout consolidation and even maintenance if possible. And that has been shown by the Emory group retrospectively with like Velcade and Revlimid combinations. And that also has been shown by the Forte trial with the addition of carfilzomib and lenalidomide. So in general, I try to keep my higher risk patients in multi-agent longer than I do my standard risk patients. And that's really the main difference from my standpoint. Now, in terms of where that's unfortunately the outcomes are still not great there. So I completely agree with Dr. Mailankody. This is the patient population where there are clinical trials looking at incorporating novel therapies, including things like CAR Ts and bispecifics as consolidation, even in first-line therapy. So I would encourage patients to seek out clinical trials if at all possible. In terms of whether risk sort of changes over time, the answer is yes. There are high-risk features that can become more overt, or the clone that basically survives that initial treatment has higher risk features. And so it's not uncommon as we know, each time the patient gets treated with subsequent relapses, the durations of remissions get shorter and shorter. So by definition, those are higher risk clones already. And I would say any patient who's high risk, who's had several lines of therapy, by definition, is already a high-risk patient. So, but in terms of actually detecting high-risk cytogenetics, these can increase with subsequent relapses.
Great. Okay, so now we're going to move on a little bit to talk about stem cell transplant. There was some interesting data that came out of ASH on there. So Dr. Mailankody, with the variety of treatments that are now available in the myeloma community, would you still consider a second transplant for patients who experienced an early relapse?
So this is patients, just to clarify, who had a transplant before and relapsed, in what scenarios would we consider second?
Correct.
Right?
Correct.
So I think at our site and our center, this is again practice that varies across the country and I think across the world, depending on where you are and preferences of patients and doctors. But broad terms, at our site and in my practice, we don't typically do tandem transplants, which is two transplants back to back, about 3 months apart, a second consolidative transplant. And the first one is few and far between at our center across my practice and those of my colleagues. So that's one way of doing two transplants. The second question, I guess, is if you had a transplant in the past and your disease were to come back after a period of time, would you consider a second transplant? And this, again, is in the context of available treatments. As more treatments become available, I think the use of a second transplant is expected to go down and has gone down. At our site, we would consider a second transplant for somebody who's had a more than 2-year progression-free interval after the first one. In other words, where we think that the first transplant had a reasonable duration of remission, we would consider it. That does not mean we would do it, but we would consider. The longer the duration of remission after the first transplant, let's say patients who've done well for 5 or 7 years and are still transplant eligible, those are patients we would consider doing a second transplant. Mm-hmm. I think it's, objectively, different groups have shown that the rates of utilization of a second transplant has gone down over time, and this is directly correlates with more treatments becoming available. We've had so many new treatments that have now become available for myeloma, CAR T cells, BiTEs, other non-immunotherapy treatments, that we're fortunate that we don't often need to go to a second transplant even when patients relapse. But that's the broad kind of parameters, I think, at our practice for considering a second transplant.
Sure. So, and Dr. Berdeja, I know this has been a little bit of a hot topic as well, but so what are your thoughts on doing or not doing a transplant for newly diagnosed patients?
Yeah, so that's from the time that determination study was presented at ASCO, right? That has been even a hotter topic these days. Mm-hmm. And I remind everyone that the determination trial was the sort of the American counterpart to the French trial with RVD induction transplant followed by maintenance versus RVD longer term going straight to maintenance. And that showed that there was a progression-free survival advantage to the transplant arm over 50%, but no overall survival benefit. And so because of that, the question becomes, who are the patients that should be treated with transplant, or should all patients treat with transplant? I will argue, though, that consistently transplant trials have shown a progression-free survival benefit, regardless of sort of the induction. And as our inductions get better, I think that overall survival becomes less, mostly because we have such great salvage therapies. But there is that concern of potential increased toxicity with the transplant and potentially sort of secondary issues down the line that may mitigate some of the benefits to the standard risk patients. So if you're a high-risk patient, I generally would recommend that we proceed with transplant first line, unless you're in a clinical trial that's looking at something novel or different that may obviate that. If you're a standard risk patient, I think that's where the conversation really becomes a little more fluid in terms of sort of the risk and benefits and the preferences for the patient. But definitely, I think transplant is still a very viable option for all patients with active myeloma.
Okay, so we're going to move on now to talk a little bit about maintenance therapy, and we already touched on this just a bit. Dr. Mailankody, a common question we get from patient viewers is what other options might exist for patients on maintenance besides Revlimid? So I think this question is based on the fact that a lot of patients experience side effects from taking Revlimid, which is not always the most pleasant drug to take. So are there other options available?
I mean, there are emerging options. To be clear, I think the preponderance data, to date at least, supports Revlimid use. There are multiple randomized studies, large ones, both here in the US and ex-US, that have shown progression-free survival and overall survival benefits to doing lenalidomide maintenance compared to doing standard surveillance. And that's what led to the establishment of Revlimid or lenalidomide as a standard of care for maintenance. The challenges, as you alluded to, there are side effects, GI side effects, fatigue, but also this increased risk of second primary cancers or with long-term use of lenalidomide, which is the reason why patients and doctors are looking for alternatives. Two agents that have been studied, at least two or three, I think. One would be Ninlaro or Ixazomib, which is a oral proteasome inhibitor. This was tested against placebo, not against Revlimid, where there was an improvement in progression-free survival benefit, but not in overall survival benefit. And was a fairly modest improvement in progression-free survival, which is why it has not yet been approved by the FDA for this indication. And we do occasionally use it in patients who are intolerant to or cannot get Revlimid for other reasons. This is an oral option, something that patients can take at home. So although it does not have an approval from the FDA, it does have randomized data supporting improvement in progression-free survival compared to placebo.
Right.
The other agent that's being tested, has been studied, is being studied, is daratumumab as maintenance. So there's a sub-Q formulation. Patients can come in once a month and get this in their doctor's office. Again, some of the studies are ongoing. The best study probably at this point is the Cassiopeia study, which was a large European study looking at two randomizations. But for this discussion, the second randomization was daratumumab maintenance versus not in patients who got initial induction therapy with a triplet or a quadruplet. And there appeared to be some benefit in progression-free survival with daratumumab maintenance compared to placebo, particularly in patients who had not had daratumumab as part of their initial induction therapy. I think we're waiting for some more definitive maintenance studies to establish the role of daratumumab in this setting, if at all. The other thing I think we already covered for high-risk patients, this idea of doublet maintenance from the Forte study, for instance, using carfilzomib Rev versus Rev alone. And in patients in the Forte study, there appeared to be a progression-free survival benefit to doing two-drug maintenance. So that's the landscape of maintenance treatments. As new treatments become available, I think we should hopefully start questioning the paradigm of indefinite maintenance for our patients. So time-bound maintenance using things like MRD to define durations of maintenance. Those are all things that are coming that hopefully will also, the side effect question, the toxicity question, hopefully could be alleviated by using fixed bound maintenance of these, either the existing treatments or more novel therapies. One last point, my colleague, Dr. Corday, presented at ASH this study of lenalidomide cessation. So this is for patients who are MRD negative and sustained MRD negative for 3 years or longer. And these patients had stopped Revlimid maintenance, lenalidomide maintenance, monitored very closely with serial blood work, bone marrow biopsy. And reassuringly, the majority of patients, albeit at a short follow-up of 1.5 years, did not relapse and were doing very well. And so the ideas of these kind where you can stop and then perhaps restart if there's any changes in clinical scenario would be another way to mitigate the toxicities associated with lenalidomide or the other drugs.
I mean, there was really, I thought, quite a lot of data on maintenance therapy presented at this ASH, more than what I've seen in some previous meetings, which I think is great because it's a question that a lot of patients have. How long do I have to keep taking this therapy? So so Dr. Berdeja, Dr. Mailankody did mention the second primary malignancies issues. So talking about these malignancies that might be caused by Revlimid maintenance therapy in myeloma patients, patients want to know what they should expect or what they should be screened for during doctor's visits if they're on long-term Revlimid maintenance therapy. And what are their chances of actually having a second primary malignancy from that therapy?
Yeah, so it's almost like you pay Dr. Mailankody to like tee me off for my answers. He very eloquently sort of which very eloquently sort of kind of told us sort of what the issue is. But what's interesting is we've always known from all of the studies, both transplant and non-transplant, that Revlimid can be associated with secondary malignancies. It's usually a small percentage, and perhaps higher, after use of alkylating agents like melphalan in transplant. And traditionally, we've seen skin cancers and secondary blood disorders like myelodysplastic syndrome, leukemia, etc. But what's interesting at ASH this year, the Myeloma 11 study, which is this humongous study from the UK, actually looked like several thousand patients, both patients transplant eligible and ineligible, kind of followed their patients, and they gave us a couple of very interesting presentations at ASH. One was about the length of lenalidomide, and back to Dr. Mailankody's point about sort of cessation, they definitely showed us that the toxicity related to lenalidomide was both sort of not only when it was used, but also for how long it was used. And they showed that, as patients kind of, in terms of length, kind of you get beyond the third and fourth year, the benefit of that continuation may not be as great as the initial years. So I'll be intrigued to see the long-term follow-up of Dr. Corday's study about sort of kind of cessation of therapy at 3 years. But what they also looked at was secondary malignancies in both groups. And definitely there, the secondary malignancies were more common in patients who got Revlimid versus those who did not, both in the transplant group and the non-transplant group. And also there was interesting is that the percentage of patients that got secondary malignancies was higher in the patients that had Revlimid induction and through maintenance, as opposed to just using it at one or the other. And so we know that risk does increase. The majority of the secondary malignancies were skin cancers, usually squamous cell or basal cell, which can be very easily managed, and so that was actually reassuring. In the transplant side, as we expected, they saw more potential myelodysplastic syndromes and leukemias compared to the non-transplant arm. But what's interesting is actually in the non-transplant arm, they actually saw higher incidence of secondary malignancies, but that could be just due to the fact that these are older patients usually that don't go to transplant. So again, remember, even if you're not on treatment, the patients that got observation, there were still secondary malignancies. So there's a baseline that you would expect. I think, in terms of the main take-home point from my standpoint was that the majority or the highest risk to the patient was still myeloma. Most patients actually died of myeloma in follow-up, many more than secondary malignancies. So even though we should be considering these very aggressively, the benefit still outweighs the risk. And so I would just recommend very close follow-up skin evaluations and routine screening, not to forget screening of other malignancies just because you have myeloma.
So Dr. Mailankody, are there any data that indicate that if you wait a little bit longer, say 6 months versus 3 months after a transplant to start maintenance therapy with Revlimid, that it might decrease the incidence of secondary malignancy?
So I guess the idea is because, as Dr. Berdeja alluded to, there's an increased risk with the back-to-back transplant and then Revlimid maintenance. I'm not aware of any high-quality data that would suggest that delaying by 6 months would decrease the risk of second cancers. It's also more cumulative over time, unfortunately. So I'm not sure that you can completely decouple the toxicity, which is in this case second primary malignancy, from the efficacy, which is clear benefit in overall survival with the Revlimid maintenance. So unfortunately, I think with this particular maintenance, particularly post-transplant, but also in non-transplant patients, there is an increased risk. We think that despite the increased risk, the vast majority of patients benefit from being on Revlimid maintenance, as was just discussed. The majority of patients, unfortunately, who have myeloma die from myeloma, not from secondary cancer. So that the overall survival benefit offsets on the serious but fortunately rare side effect of second hematologic cancers.
Okay, so now we're going to move a little bit into disease monitoring. And there were actually quite a number of presentations on that at this year's ASH. And I think that, many of them sort of centered around mass spectrometry, which is really sort of an up and coming analysis method. Maybe not incredibly widely available at this point, but certainly it looks like it has some promise. So Dr. Berdeja, can a patient ask for mass spectrometry testing? And are there certain cancer centers where this is routinely being used? Are you using it at Sarah Cannon? And if it's not being routinely used, how far off do you think it is before it will be routinely used?
Yeah, no, so that's a great question. So the short answer is yes, you can definitely ask, but you would have to go to a particular center that has capabilities for this technology. So at Sarah Cannon, unfortunately, we do not have this. Mayo sort of has been leading the way in terms of developing this technology. And the hope is that actually this is actually a very an easier technology than what we normally use right now with the serum protein electrophoresis fixation and less faster results, less taxing, less on stats. So the hope is that this will be soon available at all centers. But at this time, we're really talking about specific centers. So you want to ask your doc things. Obviously, we send things to other centers all the time if we want to get a specific result. But it doesn't hurt to ask for sure.
Mm-hmm. Great. So, and it's a blood test, right? So we'll just sort of put that out there. It's really it's a test that can be done from a blood sample. So Dr. Mailankody, will this testing pick up if you have just light chain only disease?
Yeah, in principle it should, and it does, because mass spectrometry, as the name suggests, is based on the mass of the abnormal protein. So higher masses, lower masses, it separates out as a separate peak. So light chain disease, amyloidosis, for instance, can all be tracked and picked up by mass spectrometry. And again, has many advantages, including faster turnaround time, quick reporting, less manpower required to read, gel electrophore compared to gel electrophoresis, and also more sensitive than blood-based testing currently. And there's hopes that at some point we'll get sensitive enough that it might supplement or replace some of the bone marrow biopsies our patients get. We're not there yet, to be clear. But I think the hope is we'll get more sensitive blood-based testing that will at some point obviate the need for frequent bone marrow biopsies. And hopefully that'll happen in the next several years. But there are several potential advantages to a mass spec-based assessment of peripheral blood.
Mm-hmm. So it seems like this would be something potentially that could be used for MRD testing at some point in the future, right? So as when it becomes more widely used. And I think that this is kind of an obvious question, but Dr. Berdeja, should MRD negativity after treatment be a standard goal? And that would be something that could be measured eventually by mass spec, right?
Correct. But to remind everybody, MRD currently is measured with a bone marrow biopsy. And that is looking at basically at deeper levels of remission than when we talk to you and say you're in complete remission. The definitions there allow for still some cells to be detected with MRD, kind of depending on the depth of that detection. We're talking potentially up to 10 to the minus 6 or 1 in a million cells where you don't detect myeloma. So it's basically just a measure of deeper remission. And as I think was alluded in before, patients who do get to MRD negativity tend to stay in remission longer. And most of the studies have borne that out. I think, and so the short answer is yes, that should be our goal. The long answer is we don't know what to do necessarily with that information. Now, trials are starting to tell us a little more. We don't know if you get to MRD negativity, if we should stop treatment, or if you're not MRD negative, should we be augmenting therapy? We still don't have that answer. And then also the caveat is it may depend on your original risk stratification. So we did see from the master trial that, where there's a study where they took patients and they enriched for high-risk patients, looking at aggressive therapy and then stopping therapy once you had met a certain criteria of at least 2 MRD negative assessments.
Mhm.
And what we saw there is that although a subset of patients did appear to be doing well now with longer term follow-up, the patients with ultra high risk disease or at least 2 high risk features, those patients, even though they reached to that MRD negative status, a significant proportion has relapsed during observation, which suggests that we should not be stopping therapy for those patients, even with MRD. So again, we're still sort of early in terms of sort of determining how to use it, but absolutely, it's definitely. I think it's if I when I talk to my patient and they're MRD negative, it definitely feels good.
For the patient too, I'm sure.
Yeah.
So, Dr. Mailankody, is it possible to have a really small percentage of multiple myeloma cells in the bone marrow after treatment, which would not necessarily, you wouldn't be MRD negative, but you would have like a small percentage of cells there, and those cells might not progress? They would just sort of sit there?
So this is the counter part of the first argument, which is that, yes, we all like to see MRD negative, no questions about it. You do a bone marrow biopsy, you get the reports back, it's all clear, no minimal residual disease using either the next-gen sequencing-based assay or flow assay. It's great to tell patients that. Patients like it, doctors like it, the teams like it. I will say, though, that it's not a prerequisite to have MRD negative responses to do well, and that's what this question, I think, alludes to. There are patients in whom we don't achieve MRD negativity with our available treatments who end up doing very well. They may have a small M spike. They are possibly MRD positive after transplant or other treatments, but then have a very long period of remission, if you will, where they don't need any additional intensive treatments or on maintenance for a long period of time. This is more so with standard risk patients, I would say, and typically patients who have had no high risk features who do well, but not quite, the complete response or MRD negative response tend to do well, which is where the challenge comes, I think, that Dr. Berdeja alluded to, which is we don't yet know what to make of the information beyond saying you're MRD negative or positive. Should we be adding more treatments to patients who are MRD positive? Maybe, maybe not. Should we be de-escalating treatments to MRD negative patients? Maybe in some patients, not all. So I think that's where the next few years will be important to integrate the high-risk features, the responses to treatments, the sustained responses to treatments, available therapies, all into one to determine what's best for our patients. And it's probably not going to be the same for every single patient, maybe determined based on all of these factors and others that are emerging.
So, Dr. Berdeja, if a patient has bony lesions, can they still be considered MRD negative? And does MRD negativity in this instance have a favorable prognosis?
Yeah, so that's a good question. And again, I think it goes back to the definition of MRD. So I think it's important to realize that when we talk about MRD, usually we're talking about getting a bone marrow sample and looking for cells in the bone marrow, and that's the traditional MRD. We talked about mass spectrometry as a different method that may be sort of kind of much more broader because it's a blood-based test that maybe will tell us more information. But remember, there is MRD by imaging as well, criteria in the IMWG, which is especially important for patients with extramedullary disease, for example, that had masses outside of the bone marrow. But the bone lesion question is a little bit tricky because it kind of depends on the modality you're using. So remember that once you have lytic lesions or bone lesions, if you're using a CT or X-ray, oftentimes those bone lesions will remain, whether myeloma is in remission or not. So just because you have detectable bone lesions does not mean there's active myeloma there. If you start using things like PET CT or diffuse weighted MRI, which is not available throughout, those are much more sensitive techniques that are looking at whether they can actually see the evolution and so basically detect or active myeloma in those lesions that are still there. And so those are probably going to make it easier for us to use this test as serial ways to determine whether you have active disease in the bones or not. But technically, yes, if you have disease by X-ray or CAT scan, you can still be MRD negative.
Okay. So our final topic for today is going to be CAR T cell therapy and bispecific antibodies, which is arguably the highlight of what we saw at ASH this year, with quite a number of presentations on CAR T and bispecifics. Really an exciting time in myeloma to have these really effective single agent drugs out there. So, Dr. Mailankody, how close are we to having additional CAR T cell therapy options with shortened manufacturing times, or is there going to be better accessibility to the two currently approved CAR T agents? I mean, this is a big question for patients. I've talked to a lot of physicians who really find this to be, especially the availability issue, is just really a tough one for them and for their patients.
So I will say with the two available products, things are looking up, at least at our site and others as well. We have more availability now such that we're no longer dealing with a long wait list of patients trying to get either of the products. So that's definitely a positive. There's obviously, I think, room for improvement because there's still the manufacturing bottleneck and other things that need to be overcome. And we're anticipating that these products might need to move earlier lines, which would open up this option for many more patients. So there's certainly probably no room for complacency in terms of access. It's getting better, but so is hopefully the field is continuing to move forward. There were several interesting presentations at ASH that hopefully will lead to potential future standards of care in the near future. So say there were a couple of different BCMA-directed autologous CAR T cells that looked very promising. So if those make it to approval in the future, those will add to the currently available two options, and more options means more availability. There are platforms of rapid manufacturing of autologous products. So instead of taking 2 to 3 weeks typically for manufacturing and then another 2 to 3 weeks for quality check and other things, there are now platforms where cells can be manufactured in 2 to 5 days, let's say, cutting short the period in manufacturing. These are still in clinical trials, but again, the early results of both feasibility of rapid manufacturing as well as the efficacy look promising. So that adds to additional options. There are allogeneic products. So for instance, we presented the update on the Allo715, which is a BCMA CAR T cell off the shelf using a donor-derived T cell. So rapid turnaround time, which also has efficacy. So that's yet another approach. There are other platforms companies that are looking at off-the-shelf allogeneic CAR T cells. And then lastly, almost all of the focus in the preceding years has been on BCMA, but we're now at this meeting starting to look at other targets as well. So for instance, Dr. Berdeja presented results from a GPRC5D directed CAR T cells, a multi-center study that looks very promising. This is now in addition to BCMA and then an option for patients who've received BCMA therapies already or have not received as well. So I would say several new updates at ASH that gives us a lot of hope for the next 2 to 3 years.
Sure. So, and I think that sequencing of these agents is becoming a much more interesting and like a really important question, right? As more of these agents become available. So, Dr. Berdeja, what is the experience with using Carvykti in a patient who relapsed after having a BECMA or vice versa? And can a patient who's previously had a CAR T be eligible for a bispecific antibody treatment?
Yes. So why do I get the tough question? Question about the update. So the short answer is yes. So the good news is there is good sequencing data. And actually, I think all of us who've had clinical trials for a long time have done this in clinical trials and seen that some patients can respond to a subsequent therapy to the same target or to a different target. But I think, it's hard to know between the commercial products. So we do know that retreatment of the same product, at least both with the BECMA and with Carvykti, was not good. And so most patients, I would not recommend that you get retreatment necessarily. Now, having said that, a lot of the data that we're seeing in terms of sequencing and the real world data and so forth, remember, these two drugs have come out pretty recently. So we don't have those patients that potentially got a remission that lasted 3+ years. Would that patient potentially then be able to, if they got a BECMA, could they go on to Carvykti? Most likely the answer is yes. And it goes back to sort of the mechanisms of resistance or why the patient sort of kind of progressed. But I have to say that when we look at sort of the real world data, or when people are looking at their own single institution data in terms of patients going from clinical standard care, it does look to me like if you have had a prior BCMA therapy and you go into a CAR T, that the responses are just not as good and they're not as durable. Whereas actually with the bispecifics, I think we're seeing that the responses tend to be very similar and may be durable, as obviously there's now data from the clinical trials looking at allowing patients to have prior BCMA. So I think if you have a patient, in my mind, if you have a patient that has all the options and your plan is to give CAR T, you want to give the BCMA CAR T first. And then if that patient for some reason is not a candidate or can't wait or needs something off the shelf, then you go with bispecific. But just with the caveat that if you go with the bispecific and then you're going to go to the BCMA directed CAR T, you may not get the same results. Now, having said that, we have now good data. Dr. Mailankody alluded to the GPRC5D, that if you actually have a patient that relapsed from a BCMA CAR T, you can be treated with a different target CAR T and actually get excellent responses. And though we don't know the durability, some of those patients look to be durable. So again, they're still completely in flux, but I think it really depends on how you responded and how long it has been since that therapy before you consider going back to the same target. So there's a lot of nuances to it that we're still learning, but the short answer is yes, they can definitely be sequenced.
Great. So Dr. Mailankody, can T cells be collected and frozen to be reused for future CAR T?
So I think scientifically the answer is yes. There's nothing to stop from collecting, freezing, and manufacturing as needed. The challenge is logistic as well as financial.
Right.
So logistic being, where do we store all these T cells if we collect them, and who's going to pay for them? So right now at our site, and I'm not aware of any other sites as well, where we would offer to collect T cells and store them in anticipation of needing them down the line. As the treatments evolve, as we use CAR T cells earlier, that might change. But for now, I think we're limited by the logistics and finances of doing it. I will also say most of the experience of manufacturing CAR T cells has been in fresh or relatively recent apheresis. So I would caveat by saying, although there's no scientific reasons to believe that you cannot store, we don't know how successful manufacturing after collection 3 or 4 years earlier would be. There may be challenges to viability, other potential issues that would need to be ironed out before we say this is definitely something we want to do for our patients regularly. But so for now, it's not an option, but might change as more data becomes available.
So, Dr. Berdeja, do you see CAR T cell therapy replacing stem cell transplantation? I know, another hard question.
Dr. Mailankody got the question about storing T cells. The short answer is no. Yeah, but no, I think this is a great question. But and obviously, if we look at lymphoma, for example, right? I mean, I think there definitely has been a movement towards the CAR T's replacing transplant in a subset of patients. So I think it definitely could happen. I think the trials are ongoing now. There are trials in high-risk patients where patients are not getting transplant.
That's going to be some really interesting data when that comes out.
Yes, absolutely. So I think we'll wait and see. But remember that it has to be a significant benefit, right? I mean, we're talking about a $500,000 treatment versus a potentially like $50,000 treatment. And so, if you get, if patients get a PFS improvement of, 6 months, is that really sufficient to replace something like a transplant? And that's also in places where we have this embarrassment of riches like us. But, throughout the world, obviously, this would be a much more difficult thing to do. And so in that case, transplant, I don't think would be replaced by CAR Ts. But could I foresee a future that where CAR Ts would take place of transplant? The answer is yes, and actually I would love to see that because that's still is a much more aggressive. I think a much better treatment personally.
Yeah. So, I mean, I think it's going to be a while before we come up with something that's going to take the place of transplant, which is, still an extremely effective therapy for many, many patients, and certainly in the rest of the world. It's much more available than CAR T. So, Dr. Mailankody, what are the distinguishing attributes of the various bispecific antibodies under investigation?
See, that's a little tough. So there's many bispecific antibodies, and the way I keep track of them in my head are target BCMA versus non-BCMA. So there's many BCMA-directed treatments, but there are two non-BCMA ones that look promising. One is talquetamab, which is a GPRC5D targeting bispecific antibody, and another one is called cevostamab, which is a FcRL5 targeting bispecific antibody. And there were updates for both of those products at ASH. Both look quite promising. Responses in the order of 60+% patients, and again, being non-BCMA, quite an attractive option because there's a plenty of BCMA-directed therapies. So that's the two non-BCMA directed treatments. Talquetamab is a sub-Q injection. Cevostamab is IV, but given every 3 weeks, so has the convenience of being less frequent treatment. Has toxicity profile, CRS, neurologic toxicity is quite similar to the BCMA bispecifics. Talquetamab, in addition, has some GI side effects in terms of dry mouth, loss of taste, skin and nail changes, which are unique to talquetamab. So that's the non-BCMA ones. Amongst the BCMA, and there's probably half a dozen, if not more, in development. One that's FDA approved already, teclistamab. And my impression of the data is that they're similarly effective and have a similar toxicity profile by and large. This is with a caveat that they've not been tested head-to-head. We're comparing phase 1-2 studies across board, done at different times, different places, but high-level numbers for toxicity and efficacy look comparable across the board. So what's different about them? I think one is mode of administration. There are some sub-Q formulations, some IV. So that's different. So you might prefer one or the other. There are differences between the frequency of administrations, once a week versus some that are now every 3 or even 4 weeks. So obviously less frequent would be more desirable to more frequent. And then ultimately, I guess what's readily available and what's not. So teclistamab is approved and therefore does not need trial eligibility or enrollment to get access to. The other products right now are available only in the context of clinical trials. The bottom line, I think, is across board, these half a dozen or more bispecifics have a response rate in the order of 50 to 75% in patients with relapsed refractory multiple myeloma, triple class exposed, triple class refractory. The rates of CRS and neurologic toxicities appear lower than we see with CAR T cells, so that's good. All of these products at this point require an inpatient stay for initial admission of the step-up dosing to mitigate or lower the risk of CRS and neurologic toxicity. And the last point of caution I will make is the risk of infections, which do seem to be, they're very effective, but they also have the tendency and potential to cause serious infections in patients. That's true for all of these bispecific antibodies. Infections like COVID or severe COVID, pneumonias, other opportunistic infections appear to be common and increasing as patients stay on this drug for a longer period of time. So I think one of the challenges for us will be to monitor patients for infections that we may not necessarily expect in patients with multiple myeloma, typically the PCP, pneumonia, fungal infections, others, to be able to identify those infections early, intervene appropriately, and come up with strategies for immune prophylaxis, surveillance of these infections more vigilantly, so we maximize benefits and lower the potential harmful side effects with these treatments.
Okay. So we're getting toward the top of the hour here, so we're going to go now for some concluding thoughts. So my final question for both of you is, based on what you may have seen at ASH this year, is there anything that you're going to be doing differently in your practice? Dr. Berdeja, I'll let you go first.
So I have to say it was a great ASH, but at the same time, there was no sort of kind of presentation that I thought was sort of practice changing. So from that standpoint, no. Having said that, I think, one of the things, that both of us actually deal a lot with is the bispecifics and the CAR Ts, right? And we always get that question about, which one is going to be the winner, which of these modalities. And so one of the benefits or potential benefits of the bispecifics was that they're off the shelf. They were going to be easier, that maybe more translatable to the community. And I think, what we've found out so far from the teclistamab, since teclistamab has been approved, is that it's actually been a little bit difficult because of the mandate to actually hospitalize patients. And so the same issues have remained with CAR T, which is actually kind of interesting. So one of the presentations that I felt would sort of help me or potentially help me modify what how we would do this is we've been thinking about how can we do this all as an outpatient, right? Because as Dr. Mailankody alluded, the cytokine release syndrome, even though it's present in most patients, it tends to be mostly grade 1, rarely grade 2. So potentially very manageable as an outpatient. And so there was a presentation from Dr. Trudell with Cevostamab, which is the FcRH.
That was a really interesting presentation. So, yeah.
Where they gave tocilizumab as a prophylaxis, basically, and they showed that you can decrease the risk of cytokine release syndrome in half, basically. Now, tocilizumab is still a very, expensive medication and may not be available to all clinics, etc. But the nice thing about bispecifics is that you're going to keep giving it. So I think we can come up with a more aggressive prophylaxis with the use of steroids, perhaps more aggressively in the first sort of dose escalation. But I think this gives us a little bit of proof that potentially we can come up with that magic solution as to how to do this all as an outpatient, because I think that will sort of expand the potential use. But I will. We have to remain sort of cautious in that, we worry about that initial CRS, but I think that the increasing infections that Dr. Mailankody mentioned, I think is going to become a bigger problem as we think that we're over that initial hump. The patient can now go back to their clinic 3 hours away and continue. It's going to be a lot of education to make sure people are making sure they're looking out for those infections.
Agree. Dr. Mailankody, final thoughts on any practice-changing information from ASH?
I echo what Jesus said, which is that, while very interesting, Ash, lots of good data, not immediately practice changing, at least for some of, two themes for me. I think one is there's still a lot of uncertainty, as this discussion kind of alluded to. Do we transplant everybody or not? What maintenance to give patients? Or what's the optimal induction? There's a lot of uncertainty still, despite, the progress that has been made. So one of the lessons for me as I go to these meetings and come back is there's room for shared decision making with patients. Patients are smart and they have their own choices of transplant versus not based on their circumstances. So the best we can do is to provide them as much information as possible to make those decisions. And these meetings help us, give numbers or data and numbers to back our recommendations or the different options that patients are facing with. So that's one. The second theme, I think, which I talked earlier and Jesus just repeated as well, which is that both the benefits and risk. I mean, we're incredibly excited about CAR T cells and bispecific antibodies, both on trials, which we've been using for many years now. But now that these treatments are available in clinical practice, we've here treated several patients with commercial teclistamab. Patients are eager to get these treatments, doing well with these treatments, and that's great. And the efficacy is the meeting is a highlight of all the great efficacy that we see. But like Dr. Berdeja, I do worry about the infection risk quite a bit longer term as patients stay on these treatments for long term. How do we best manage infections? How do we reduce the risk? If patients are getting this at lower volume centers where there may not be the same level of comfort or expertise managing these side effects, will we be, seeing more infections and complications from infections when we do that? And how do we best educate patients, caregivers, and doctors to minimize that risk? I think is going to be a big real world challenge in the next year or two as more of these treatments become available.
Great. Okay, so on behalf of the MMRF, I'd like to thank our guests today, Dr. Jesus Berdeja and Dr. Sham Mailankody. I'd like to thank everyone who is viewing us today for taking time out of their day to watch this presentation. For those who didn't get a chance to view it in its entirety, it will be recorded and it will be on our website within the next few days. So probably next week sometime it'll be posted if you want to go back through and listen again. I would like to thank our sponsors, Adaptive, Bristol Myers Squibb, Genentech, GSK, Janssen, Karyopharm, and Takeda for their sponsorship of this session. And to all those who are watching, if you have additional questions about what you heard today, please call our MMRF Patient Navigation Center. Their phone number is 1-888-841-6673. Our center is staffed by oncology professionals who will be happy to answer your questions. Thank you so much, everyone, and have a great day.
Thank you.
Thank you.